Hello, and welcome to today's webinar, The Winning Edge for Leading Digital Innovation at Scale. My name is Jay Asser, CEO Editor with HealthLeaders, and I'll be your moderator for today's session. Before we begin, I'd like to share a few housekeeping details to help you get the most out of your experience. First, to ensure that you can see all the content for the event, please maximize your event window and adjust your computer volume settings and/or PC speakers for optimal sound quality. You'll find the main menu at the top of your screen containing all of your attendee tools. All tools are resizable and movable to personalize your webinar experience. We welcome your questions and participation. Please use the Ask a Question tool to submit any questions you may have during the live webinar or as you watch the on-demand recording. We'll do our best to address them during the Q&A portion at the end of this session or via email at a later time. You can submit real-time feedback using the emojis at the bottom of your screens. And finally, if you experience any technical difficulties during today's webinar, please close out your other open browsers or applications and refresh your internet browser. You can click Help in the top menu for more troubleshooting steps or reach out to us using the Ask Question tool. And now it's my pleasure to introduce our panelists for today's session. We have Crystal Broj, Chief Digital Information Officer from Medical University of South Carolina, Lynnette Clinton, CIO at BayCare Health System, and Kopal Seth, Associate Chief Medical Information Officer at Phoenix Children's. Thank you all for being here today. Would you please mind just giving us a little bit of background on yourself and your organization? Crystal, could you start us off, please?
Sure, happy to. Hello, everybody. I'm Crystal Broj. Like Jay said, I am the Chief Digital Officer at the Medical University of South Carolina. We are the comprehensive medical system in South Carolina, covering all 46 counties. We have about 33,000 employees, over 16 hospital locations, and more than that in clinics. We're also a university with 6 graduate level colleges and a major research institution as well. I've been here for about 4 years running digital transformation. I'm doing everything from voice bots to AI agents and having all around fun.
Thank you, Crystal. Lynnette, can we hear from you?
Yes, sure. My name is Lynnette Clinton. There's some similarities here with Crystal. We are in BayCare is the largest academic health system in West Central Florida in the Tampa Bay area. We cover a little more than 4 counties right now. We're putting our 17th hospital in a 5th county in a short time frame. So it's actually being built right now. We have 34,000 team members, and we have a large ambulatory footprint and really just moved our way officially into academic health, actually. So we have the largest growing GME program in the country. So that's our what we've been really focused on is growing our GME program and really helping to bring more physicians into this area. Personally, I started with BayCare 10 years ago. The first time I did leave for a short period and come back. And I've been in healthcare IT my whole career, almost 30 years in healthcare IT or in IT in general. And looking forward to the discussion. So lots of focus here, lots of AI talk here, of course, at BayCare, but a million other things going on too. So looking forward to the discussion. Thanks.
Thanks, Lynnette. And Kopal, can you please tell us a little bit about yourself and your organization?
Yeah, I'm Kopal Seth. I am coming from Phoenix Children's. We are a large tertiary center covering the Phoenix metropolitan area. We have a vast complement of subspecialties, so we have a lot of complex patients that come here. We have satellite hospitals that we are currently, satellite places that we are currently opening to increase our patient access. And we also have a lot of learners. We have a teaching hospital, so a lot of learners. And I have been at Phoenix Children's since 2007. I am a pediatric emergency medicine physician by training. That's my clinical background. And I've been involved in the IT worlds for a long time now with, initially starting when we moved from paper to digital, and continuing to participate in enterprise-wide projects. Moved into the associate CMIO position about 2 years ago, and really enjoy being that link between IT and our clinical world. And excited to talk on this webinar. Thank you.
Thank you all for being here today and joining us for a topic that I know is very timely to digital hospital leaders and really all hospital leaders right now. As hospitals and health systems, as we know, we have more digital technologies available than ever, but adopting a technology and creating meaningful impact are two very different things. And as organizations invest in technologies like AI, virtual care, other digital tools, leaders are very focused on determining what is worth pursuing, integrating it into the organization, and ultimately making it work at scale. So today we're going to explore what it takes to create measurable value with digital innovation and ensure these technologies actually work for clinicians, staff, and patients. So with that said, I want to start by asking each of you, how do you go about deciding which digital innovation is worth pursuing right now? What type of criteria are you applying? And really, how are you differentiating what is promising from hype, which we know there's a lot of right now? So Crystal, I'll throw it to you first. Could you get us started?
Yeah, sure. I think we don't look at initiatives until we look at problems that we're trying to solve. There's so much tech out there today and everybody's trying to solve a problem. But I think what you really have to do is look internally at what your organization's key goals are. And then, who are we solving it for and how will we know if it worked? Is it a real operational person, a real worker, a real clinical problem? And do we have an accountable business owner for that problem? So it's not just IT for IT's sake. And then really knowing what the definition of success is. A lot of tools will promise you the moon and the stars, but you have to know for your own organization what you're trying to achieve with that problem and what you need to do. Decrease calls that come into the call center, increase check-ins at the front desk, those types of things. And be able to measure that before a pilot ever begins, and then be able to watch that as you roll out the pilot to make sure. And then that helps you scale it. It's really important to make sure that we're not just adding on to workflow or making another destination for a patient or a clinician, but instead taking work out of the system. I think it's important to, we've had digital scheduling, voice automation, AI-enabled workloads that have worked really well. And then we've had some pilots that did not meet our needs, and knowing when to cancel that as well is just as important.
Great. And Lynnette, from your perspective, what are you seeing and how are you applying that criteria to differentiate right now?
Yeah, Crystal gave a great list. I think some of those things were on my list as well. Some of the things I would add, it's really important. With measures of success, we track those as well, and specifically like from, to, by, when. So every project we're taking through now has a clear measure in there, and so we know, and the approvers know if this thing is succeeding or not succeeding. And we don't do a pilot with everything, but we do with some things. And sometimes you're just piloting the workflow. Like, you're going to go forward and do this thing, but you're just, like for us with 16 hospitals, we have the ability to choose one area of workflow and refine the workflow there. And then the rest of the rollout is great. So that's another way to scale. But you have to make sure that when you talk about pilot, people don't think that they're just trialing this thing, especially if you made a decision to go forward as an organization. Sometimes I change the words up there or explain, we're just piloting the workflow. We're getting the workflow right with this new tool, but then we're going to roll that out. The other ways we measure here are, we have a standard, really it's a business plan. We call it an SOC, service outcome cost. So we have a standard way of putting these things forward. And what really makes them, the best ones that work well are right when you have a problem to solve, but when you have a sponsor who is truly committed to this outside of IS, that's when you have that commitment and that sponsor, and there's clear buy-in for something, that's really what makes something successful.
And Kopal, can you add on to the answers by Lynnette and Crystal there?
So they've done a really great job of answering the question. A lot of things that I was going to say as well. I will tell you from a clinical lens, I really, it's looking at the real world problem, not the technology. What are you actually trying to solve? Is it reducing clinician burden, improving patient safety? Is it enhancing quality, helping the experience for families and patients and families, or even helping us educate the next generation? The important part is really, I think, reducing friction in care delivery, not more clicks or complexity. So that's what I'm usually asking from a clinical perspective. Innovation doesn't always have to be revolutionary. Sometimes those high value projects are really the things that are frustrating experiences for people that clicks 1,000 times a day. And that's the goal, is to try to remove some of those. And really looking if technology can fit into the clinical workflow, and whether we can measure whether it's making a difference. And so I think that's, for me, that's where my role as the bridge between a clinician and IT is really valuable. I can look at it from both sides, and does this actually make sense for the way we deliver care? And so, the question, again, is pretty simple. Does it make care safer, improve patient experience? And if the answer to many of those questions, efficiency, helping the organization achieve its goals, if the answer to those is yes, then, and we can demonstrate measurable improvements in safety, efficiency, quality, then I think the innovation is worth pursuing. And it's not, it may just be hype. So.
I think that's also a good point in terms of speaking from the clinician lens. I know we'll get into that in a few questions here about workflows. But next I want to ask and focus on, in terms of scaling, what have your experiences been at your respective organizations for trying to create system-wide adoption with some of the technology tools that you're implementing? Lynnette, could you tell us a little bit about your experiences?
Yeah, I would say that the easiest way to scale is when you have something useful, right? Something that's intuitive, that people want to use, and we tell them about it, but they also see their peers using it, and there's clear value to them. If there's not, it's essentially regulation at that point. It's something they have to do, and then scaling is different at that point. But if it's something they want and adds value to them, that's the best way to have scale made easy.
And Kopal, how have your experiences been at Phoenix Children's with scaling tools right now?
I think I can boil it down to trust. It's trust between the people using it, the end user, and IT. And I feel like building that trust is really important to scaling anything. Again, I agree with Lynnette. It's, the usefulness is really important. And I think if it doesn't fit into their workflow and the way they work, it's not going to be adopted, whether it's a clinician or a non-clinician. If it's not fitting into a workflow and they can't see the value in it, it's really hard to adopt something. I think change management is just as important as the technology itself. Change needs to be positioned in a way to make people's work easier rather than another administrative burden. They need to understand not only how something works, but why it matters and why it will make the work easier, whether that's in a clinical space or a non-clinical space. I think and I also think having the right leadership and support behind it also is really important. I think scaling requires that. You can't just throw it out there for something for users to try to, adopt without having some support behind it. I think system-wide adoption really is way before the go live. It starts with listening, understanding that workflow, making sure providers, staff feel heard about the issues, and then what solutions, and being a part of that solution really helps adoptability. So.
Yeah, change management, as you mentioned, is an important aspect to this. I think leadership alignment throughout the leadership team, executive team, I think is going to be vital. Has that been your experience, Crystal, at MUSC, and what have you seen when you're trying to scale?
Yeah, absolutely. I think my friends definitely hit it. It's not a technology thing, but really a change management problem. A successful pilot proves that something can work. But when you start scaling it, then you're seeing that the organization can work differently because of the technology that you're putting into place. And like everyone said, the frontline champions, the executive sponsorship. But one thing that we learned is don't confuse deployment with adoption. We can put the tool out there, but if people aren't using it and being told what they're using it for, then we have not succeeded. And it isn't just the frontline employee, but the managers have to be prepared for that new adoption model. If we save somebody 3 to 5 minutes a phone call, that might add up to a certain amount of time per day, but then what is that person doing with the rest of that time that they've saved? If we don't tell them what to do, if we aren't doing something else with that time, helping them answer a call that's more complex, giving them the opportunity to call out for referrals or setting up appointments, then we really haven't solved any problem at all. And starting slowly, like we said, we started with our voice bot, and it answers incoming calls. We started just on 4 lines, and then we increased it, and we increased it again. Now the voice bot's on 140 lines. I'm handling about 3.5 million calls a year, deflecting about 25% of them. We did that at our patient call centers. We realized that that was working well. We moved it to our revenue cycle call centers. We've moved it to pharmacy. But that doesn't happen just because the technology works. That happens because we get the other people involved along the way, and they can see what we're doing and how we're making that change. It really falls into that, making sure that people know what they're doing because we're saving them time, or AI is doing something else for it.
Great points. Next, I want to give each of you a chance to focus on a specific digital initiative at your respective organizations that has been successful of late, and what exactly has made it successful. So give you a chance to brag a little bit about what's been going on, what's been working well. Kopal, can you tell us a little bit about an initiative at Phoenix Children's that right now that is proving to be particularly fruitful?
Yeah, so I'm going to come from a clinical lens. So one example that I think really demonstrates value is our work with AI-assisted chart preparation. So one of the challenges that we really hear from providers is, particularly in the ambulatory setting, but both in inpatient and outpatient, is the amount of time it takes to prepare for a complex patient's visit. We have a lot of chronic patients at our facility. Clinicians can spend a significant amount of time going through multiple notes, results, encounters, other parts of the chart, the medical record, just to understand what has happened to the patient since the last visit. So we developed an AI-assisted chart prep that can review and summarize a lot of that key information in the chart before the visit. And the goal isn't for AI to make any clinical decisions in this case. It's really to help the provider get oriented more quickly so that they can bring that information up to the surface. What we've seen with that is we've seen improved efficiency in preparing for those visits. So providers can then get to the key information more quickly. And it might actually, it helps surface details that might potentially have been missed with manual review, because manual review takes time. And when you have a very large chart. And it really gives the clinician a better starting point when they walk into a room. And it really allows them to spend less time preparing in the chart and more time focused on the patient and the family. What really made this successful for us is having division champions who really understood the clinical needs and partnering closely with operational leaders who understand how that ambulatory workflow, those workflows actually work. So we treated clinicians more as partners in the process and really listen to what is it the information they needed surface, because it really depends. It's different division to division. And allowing that tool to evolve based on what we've learned from the people using it is also improved its clinical value and success and helped it better get adopted into their workflow. I think what's important for us when we're looking at these AI initiatives is we view AI as an assistant, but not a replacement for clinical judgment, so that the provider still needs to review and interpret that information. But the value is in reducing the amount of time it takes to get to the right information. So I feel like that's an initiative that's really been successful for us.
Great. And Crystal, what have your experiences been like right now?
The one I was talking about before, our voice bot has done great. We've been able to expand her to Spanish. And so, and the various things. We've also connected her now to our facilities phone lines. So she's actually triaging facilities calls, a light bulb's out, a water main's broken. And now we're creating an HR version of her that will answer everything from policy questions to allowing our staff at 2 o'clock in the morning to request a day off for tomorrow or find out where they should take their sick child, and then setting up those appointments. So really having that full circle of one thing, Emily, that takes care of all of our patient and staff needs is great. We've estimated that last year we saved about 37 FTEs worth of time by having Emily answer these calls. And that doesn't mean that we eliminated 37 people. It means that we took administrative work out from a workforce that was already stretched and allow them to do higher level tasks, setting things up so that you can get an MRI and a CT and the appointment all on the same day, so you don't have to come to campus twice, for example. The goal isn't to replace human interaction with these tools, but instead it's to let humans stop doing work on stuff that doesn't have to be done by a human and letting them actually do the things that they got into healthcare for to begin with. And I think that's some things that are very powerful.
So we've heard two cases of AI implementation. Lynnette, are you going to make it 3 for 3?
Yeah, I'm going to talk about a totally different one. We're working on Crystal, what you're working on, Crystal, and we've not implemented it yet. So I have aspirations to be where you are. It's a lot of the conversation we have. Of course, we've done ambient listening and different things like that. We're doing other things with ambient in our nursing. But the one I want to focus on today is a story that one of our hospital presidents told me last week. We've created an agent for him. We have a modern data warehouse, and there's an intelligence tool that was released. So we're able to create data sets for a period of time and allow a user to ask questions to that data set. So it's, tell me, he can ask all kinds of things to this data set. And it's really around historical, clinical and procedures and charging that happened over a period of time. So this hospital president said, I really think I need a new tower to provide more services, but I need help creating this business case. So he started asking his little chatbot all kinds of other questions, specifically about building this business case to help him justify what he thought that he needed. And he said it really, so much information came out about how he could justify his business case that it was overwhelming. Like he said, this is the gap in procedures that we could do. What should we put together in where, when people have multiple procedures at one time, what should be clustered together, the design of the building. So much of that, he's thrilled. He stood up in one of our meetings a year ago and said, one of the biggest gaps we have is data. And I almost fell on the floor because we have so much. So we have turned him around, and now he's an advocate for the tools that we have. What we didn't do well was obviously show him what was available. So we worked with him to say, show us what you need, give us examples. Where have you seen dashboards before that you would want? Or let's get beyond the dashboard. Let's get to insights. What do you do with the dashboard? How do you action on these things? So that's some of the things that we're also working on in parallel to some of the other sort of more common things that everybody is kind of working on. Was a unique one for me. And I was so excited to hear him talk about it last week.
That's great. And I think that's a good segue into our next question and something we've been talking a lot about so far, which is when you're implementing a lot of these new technologies, they might seem great on paper, but when you get them in the hands of your frontline staff, you never know if they're actually going to prove to be useful and integrate into their workflows. So how are you going about ensuring that whatever you're giving your staff, these technologies, that they are going to be beneficial for them, they're going to, maybe most importantly, use them and not just ignore them, they're just going to collect dust. So Crystal, what have you found to be helpful in determining what is going to be used by your frontline staff and making sure that you're it's an effective tool for them in the end.
Yeah, that's always the important part, right? Is to bring those frontline staff in before the solution's designed and have them sitting side by side while you design it. We do what we call here big work sessions, and we bring in everybody that is actually involved in the project on day one. So we're going to go with this technology, whatever it is. We bring in the call center people and their managers and marketing and IT and legal, so that everybody knows what this project is, how it's going to go. Now we walk through the workflow. Now, IT has no idea what happens on the front lines, but it's good for them to understand that when they connect this API to this software, it affects Susie at the front desk, or it affects Janet that's answering the phones, and what happens when those connections don't work. But it's also important for Janet to be able to say, this is how I do it today, and I already have 2 screens up, and this is too much work if I have to open a 3rd window, so that we can make sure that the workflow flows a lot more easily for them. And then once you build it, have them test it, have them work with you when they're testing it so they can start to get used to adoption of it. And when you get ready to launch it, go back to that problem statement and say, this is the problem that we're trying to solve. Have we now given you something that solves it? And sometimes you can't do the end-to-end problem all at once. Sometimes you have to figure out what the biggest friction point is and just do that and see if it makes a difference before you deploy the entire thing. I think most people don't resist technology as much as they resist the technology being done to them. And I think that's really why we want to bring them in at the beginning.
And Lynnette, has that been your experience too at BayCare, is just involving as early as possible?
Yeah, definitely. And I think there's different times within the project we do that too. So it's at the beginning, it's definitely within like user acceptance testing, and then or piloting, getting them involved in helping to design. Sometimes you can get with one of your vendor partners, and you're helping to design their solution. And we definitely showcase those times when we can do that. And we do that with our frontline team. We did that with some nursing workflows. And we somehow, I think like a local TV, news group picked it up, and we had our frontline team speaking on the camera. Like it's their product at that point, and they show so much ownership. We do a lot of that internally too, so that it's part of our change management and helping with that workflow adoption is to have the frontline teams tell their peers why it's valuable for them. So we just get them right in the marketing campaigns and everything, communication campaigns, everything we're doing, we include them at that frontline level. They sell it to their peers better than anyone in IT can.
And I know this question is near and dear to your heart, Kopal, and you've been speaking on it a lot in this session. But what have you seen in terms of trying to get that frontline staff engaged early?
I mean, Crystal and Lynnette have highlighted a lot of the things. I think it's really important to recognize that leaders don't always know the answer, that the people doing that work every day, and they understand the workflow better than anyone else. So listening and involving them early is really important. As Crystal was saying, technology done to them makes everything a challenge as opposed to being done with them. So what she said is spot on for us and what I found. And then, I think because we really want to understand what actually happens in the environment, not what we think happens, because we have a lot of thoughts of what we think happens, but what really actually happens. And I think creating, translating the words from the IT world, for example, to the end user is really important, because they have different languages of speaking. And so you need to find that connection. And I think that really helps you embrace new ways of working, because I don't feel like if there's that sort of language barrier, it's not, it creates a challenge for adoption and for really having technologies, be successful. I think another thing that I found that Crystal highlighted that's really important is that big work group. Working in silos has been a real problem. And so you obviously can't have a big work group for everything, But starting with a big group and having everyone at the table really highlights the things of where you can then sort of break off into smaller work groups and create success in, a technology. So I think those are really important things. Another thing that I would say is really important is really being able to say, we hear you. That doesn't mean we're implementing every request, but really sometimes, there's obviously things that are reasons you can't do something technical, financial, regulatory, whatever it might be. But I think people are more receptive to change if they really feel like their concerns were being considered. And if you find and it may lead you to a different solution. So I think that that's all sort of along the lines of engaging frontline staff very early. They can't just be a checkbox at the end of a project. They have to be involved in the process.
Okay, good points. Okay, so we've talked a lot about appealing to your staff and making sure they're on board. But how about also making sure the leadership at your organization is on board with actually investing in these tools and putting resources into them? How are you making the business case right now for some of these digital investments? And how much do you value the short-term ROI versus the potential of what it could be down the road? Because as we know, some of these technologies right now aren't delivering maybe the returns that you ideally want right now, but in the long term, they may provide those returns in more ways than one. So how are you making that business case right now? Lynnette, what has your experience been at BayCare?
Yep. So we've had a strong governance process in place here for a very long time. I inherited it, I support it, I understand, and I've evolved it a little bit. But so we have a standard process for our business cases, what the value is. Not everything has financial value. So we understand that, and the committee doesn't approve just everything about financial value. Sometimes there are other things, or there's softer things that are a little bit difficult to measure, but everything would have some sort of measurable ROI, whether measures of success. We talked about that a little bit earlier. But sometimes with this new technology, there's a little bit of which we don't do very often, a very small portion of the time. We go in as a leader and say, with my experience and my partnership with a certain particular vendor or whatever that is, trust me, I will deliver later. So there's a little bit of that happening right now as well. It doesn't always happen, but we're doing a little bit of that right now. We bought an enterprise license for a specific amount of money with our ERP vendor that had strong promise. So now we're saying we're going to do a short-term contract. We're going to prove that out, that it pays for itself and then some. But we didn't really have a lot of long-term industry data, or it wasn't a product that was in the market a very long time. So you couldn't say, well, this thing has a tried and true record, because it didn't yet. So there's a little bit of that where we'll turn it off over time if it hasn't proven value, but I can imagine that it won't. The problem there is that you need to have the change management discipline within my own team to make sure that we're fully leveraging that tool. So that's what's happening now. It's like, yeah, I can see it, but now we need to change the way we work to make sure that the organization gets the value there. So I think also there was something else, but you come back to me. Maybe I'll remember it.
Kopal, anything you can add on to what Lynnette said there?
Well, I think Lynnette really, I'm not the numbers person. I'll tell you that for sure. I'm not the numbers person. So, but I think Lynnette really said it, that it's not always a financial ROI. Certainly that's important. But I think you really have to figure out what current state is before you invest in a technology, so that you have something to measure against, and that can help look at your return on investment. I think if you can't just look at it through a financial lens. If it's providing safer care, better quality of care, improved documentation, those are returns on investments. Or if you're investing in a digital investment that helps you improve your research capabilities, those can ultimately lead to better patient outcomes, and that is also another return on investment. Having a MA or clinician save 15 to 20 minutes when they're preparing for a visit can allow them to do higher value clinical activities or see more patients, and that can translate into financial, ROI. I think you have to look at both the cost savings and the additional value that comes from, making people more efficient and then allowing them to have better care for the patients and the families.
I argue a lot of those, you can turn those into financial benefits as well. Just like you said, if you are able to do more visits, what we've been finding with some of the things that we do in the practice is that now they can have a life after. So not necessarily more visits, but so there's a lot of times those that don't seem like they have direct financial benefit end up having a financial benefit anyway. Maybe not 100%, but there's still a good percentage there too. Just have to have the financial partner to help you dig into those.
Yeah,
that's where you start
making the time of
work, right? It's hard to measure joy, but if I actually get to go see my kid's soccer game or something after work because I'm not charting all night long, then maybe I'll stay in my job longer and you don't have to replace me. And there's a cost to that as well.
There is.
And that's sort of a return on objective. So I kind of look at that as soft green dollars when it's something that, we know there's value to it, but it's really hard to touch, as opposed to revenue generated, collections. You have cost avoidance too. How do you measure cost avoidance if we don't have to do this because we've done this ahead of time? Staff time returned and call deflection. We've talked about making throughput. Have we created new appointments by that? Have we gotten new patients for that? We put in a digital tool on our digital front door that has better AEO and SEO than we've had in the past, so patients can find us, because patients are not just going, let me go to the health system website and see if I can find it. No, they're going to Dr. Google or Dr. ChatGPT and going, I'm looking for someone who can help me with my knee pain. And then because we have optimized our web pages with AI, they are actually finding Dr. Crystal, and you can see my schedule right on the website and schedule that appointment. When you have 200,000 clicks because of that weren't there before, that's a measurable item unto itself. But does that create downstream revenue? Yes, possibly, but we bought the tool so that we could be seen, and it's sort of table stakes these days, right? Quality, safety, equity, all of those things are just things that we need. But there's one tool that I'm looking at right now that we're having a hard time proving that ROI up front, but we're probably going to go into it anyway because it will give us experience using a clinical decision support tool that we don't have today. And just to get that experience will be worth the tool, because it will put it in the hands of our providers and let them start to practice with it and start to use something like that. And they will gain a lot from that. And you talked about GME, Lynnette. Letting our new doctors that are coming through being able to try some of these tools is something that's important unto itself. It's just an educational piece, so that when they work for us or someone else later on, they'll, oh yeah, I did that when I was at MUSC, and now I know how, whether it's Ambient or one of these other tools. And there's value in that too. There's value in being relatively one of the first that actually has these types of tools available. That opens up a whole different set of doors, right?
And it helps with recruitment of them in the end, right? Like, hey, I loved using this. I don't want to go back to not, I think it helps recruitment. There was one that I did remember, the thing that I couldn't think of before. It was really around having, and I think about it with our work in contact center and calling and automating some of those things, that, I'm looking for the first project to pay for the next project in there. We'll see the first one, but then after that, I want each one to make measurable improvements and pay for the next project. So I think that's another way that we're, proving out ROI and trying to keep moving forward and improving things with the limited resources that you end up having in with people who work those jobs. There's just not that, it's a lot of high turnover. That's the other thing too. It's how I went to our HR department to say, where should I look for opportunities for AI or automation? Tell me what the high turnover departments are and which departments you have the hardest time filling. And we'll focus our efforts there to see what we can do with more automation.
Yeah, that's great.
Yeah, all great points and insight. Lynnette, I liked one of the initial things you said, which was a lot of times right now it's just a matter of saying trust me, and having that trust from your leadership to know that this is going to pay off. I think that's also a good transition to the next thing I want to talk about.
I would say you can't use that card often.
No.
So it's when you have to really reserve.
One.
You get one once in a while.
So next I want to talk a little bit about AI, which of course is constantly evolving right now, and will be for the years to come. So, we've already kind of figured out that something like ambient listening is an effective, kind of a low-hanging fruit to implement, that we know is going to work. But going forward, where are you seeing the other opportunities right now for AI, and where do you also think maybe organizations should be a little bit cautious with how they're dipping their toe in the water? Kopal, can you start us off on this?
Yeah, so I think we've really covered, AI helping in that documentation space, decreasing that burden, really helping with note generation. Those are kind of things that we've all talked about. I think the next step is really looking at AI to support, clinical decision making by bringing together the patient's history, clinical data, and other relevant information to predict, for example, when sepsis might be coming, when a patient might be approaching sepsis or they're going to be clinically deteriorating, those kind of things, but still keeping the clinical decision in the providers, that keeping them in the driver's seat and keeping that decision making to them at the end, but really pointing out, showing patterns that will help in patient care. I think that that's sort of the next step where I see clinically to be really helpful. There are ways to predict, looking at radiology studies, whether there is a patient that is at higher risk for a clot, for example, or decreasing the risk of having a pressure sore based on, things that we look at, and having AI help us, look at that information to determine, these patients that are in CAS, will they get a pressure sore? So those are the kind of things that I think are the next steps. Where I do think that we really need to be cautious and be very thoughtful is particularly in medical education. As AI becomes a part of clinical training, we have a lot of learners with us, and so we have to make sure that these learners still continue to develop their strong independent clinical reasoning. We don't want the idea of never skilling, that they never gain their skills because of these tools. And they need to, I think that's part of learning in terms of their, training, is learning how to use AI appropriately. We don't want it to become a crutch that prevents trainees from developing those foundational skills they need for safe, independent practice. You need to teach them how to use AI and when to trust it. And not only how to use it, but when to trust it. And then, really that they have to remember to apply their own clinical judgment. You don't want to create AI-dependent clinicians. You already see that sometimes in those who have been practicing longer about de-skilling. So you have to, I think that's where you have to really be cautious. You want, AI to not replace them as a great clinician, but really to know when that makes them better. So think better, not think less. So.
Yeah, that's a good point. And Crystal, from your perspective, what are you seeing with AI right now and in the future?
Yeah, I think I'll take it from a different perspective. I totally agree with everything Kopal said. But I think there's a lot of work we can still do for administrative burden back of the house. I think we have a lot of antiquated problems in hospital systems. We still fax orders. Let's just start there. And then, you have to take it from the fax queue and put it into Epic or what your EHR, then pop it over, and then somebody's actually touching those queues and moving those things around. I think there's a way to start to put some agents in place with guardrails, with oversight to make those things go by faster. I think all that administration time is definitely something that we are not doing enough of yet. I think we'll have a lot more AI agents that help our teams answer questions, like in the call center, be like, okay, well, so-and-so wants to get an appointment with Dr. Lynnette. And is she the right person, or, in her office? And AI will be able to go, well, Lynnette's not available, but Crystal is, and she works with Lynnette, blah, 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 something, so that and I think patient navigation is one that is huge. If you think of a Domino's pizza tracker, when you put the order in, what's happening next. Most patients' health systems are a black box, and they have no idea what happens next. I went to primary care. Now I have to go to ortho. Now I have to go for an MRI. Like, when does this journey end, and what happens along? Oh, now I need a prior authorization. Oh, wait, no, I need to pay a copay. I need to ask for financial assistance. Where do all these pieces go? If we could just give like one place where you will get everything you need for your care journey, that's my ultimate dream. I think we're a ways away yet. We're building pieces of that. But for a comprehensive system that makes it seamless, and that's what patients are looking for. I mean, they don't compare us to the health system down the street. They compare us to the digital experiences they have with airlines, with Amazon, with other things where it's very, very easy. Amazon will remind me that I bought dog food 2 weeks ago and I need to get biscuits for Stanley next week, but it doesn't tell me that, oh yeah, by the way, you got to check on your prior authorization to make sure that you can schedule your appointment for your biopsy. So, that's the part where I think we have a lot of opportunity for that, but we really are going to have to, monitor it, scale it with governance, make sure that things are working okay. And like Kopal said, the closer we get to clinical decision rather than supporting one, the higher the bar should be for what we're teaching and what we're actually expecting our clinicians to do.
Great. And Lynnette, what can you add on to both what Crystal and Kopal said?
They made excellent points that I would have on my list as well. I'll add a few other things. I feel like this opportunity with AI gives us, it's like a doubling down of automation. So we've been automating for years. I mean, I'm a computer programmer by trade. That's what it is. And we've been doing robotics process automation, RPA, for many, many years. So when people ask me for AI, I take that as them asking me for help with automation. And whether I solve it with a script, or I solve it with an RPA bot, or I solve it with AI, I don't think they care. But I love that it really gets people more like reinvigorated about automation, and it helps them think differently about what we can help them with. So all kinds of departments we're thinking about, like, why do we still do abstracting for registries? I think we could make that easier. There's just departments out there that I think we could, really help with automation. The other thing I think about this as an opportunity is we've had the EMR has held a promise for a few decades now of having all the patient's information at your fingertips. So from every, hospital in your area, everywhere that patients gone, we have connections to these health information exchanges. We have all the information about all the patients, but who could ever distill that down to make it useful? No one. So I think now with AI, with other tools like this, with intelligent automation, we can finally leverage the EMR and what the dream of that was. But I don't think up until now, until we have these AI tools available to us, that we really could ever leverage the dream of the EHR. So I think that's our big opportunity as an industry. And then other things I would watch out for, I would watch out for shadow AI. I think that people are, building little bots and all kinds of things and automations that we're not aware of. So we have to watch. There's multiple layers of that. So that's one of the things we have to watch out for. But I would take the de-skilling Kopal to another level too. You're right. We have to watch out for de-skilling when people get reliant on it. But I think that's already happened with the EMR. We talk about cyber downtimes and preparing for a cyber downtime, and we realize, and I said, we need to make a list for just-in-time training for physicians and nurses and every other department to say, remember the EHR does this for you, and it's no longer available. Now you have to do these things manually, and here's a quick, tip sheet on how to do those things again. It's like we have to have sort of reskilling just in time for an event like that, or a downtime when your AI is no longer available to you. Like, but I think we're going to have to prepare for it just like we do the EMR.
You know, it's funny, Lynnette, we have a upgrade coming up, and one of the things one of my providers asked is, can we create a cheat sheet because we're so reliant on the EHR? So it's completely highlighting what you're saying. And they were like, well, how do you remember, you know, in these order sets what we have to do? And I was like, well, it's your clinical judgment. So it really, you're highlighting exactly what I was just asked. So
we're trying to really do some cyber hardening, and that's a continuous improvement. And I was like, I want a binder that somebody could drive to Staples and make a bunch of copies of orders and tip sheets, and I hope I never use it, but I'd like to have it.
Yeah.
I wanted to go back to something Crystal was just talking about in terms of consumer and patient expectations, and how a lot of these digital investments right now, you know, are also trying to meet those expectations. So how are you at your respective organizations trying to achieve that? What are you seeing in terms of the disconnect right now between what patients want and what providers, hospitals currently offer, and how are you trying to bridge that gap? Lynnette, could you start us off on this?
Sure. And actually, Crystal mentioned it. We're working on digital patient care journeys, but that's a whole process in itself, right? You can't do them all at one time. You have to kind of bite off pieces. So we're proving out 2 journeys now, and it's really just the most complex ones we're working on. But I think you're right. Patients compare us to the airline industry and other things, which are complex or benign in sort of their own ways. We've created so that's one way we're helping to solve that. We're trying to give them more omni-channel options. You know, here in Florida, we have a whole variety, and you have it everywhere. You have Phoenix too, and actually South Carolina too. You have the same sort of very mixed population, by generation, by age, by desires, by tech savviness or not. And so we need to have options. You know, we need to have somebody who, yes, I want to have the digital agent that can handle a lot, but I want it to be very easy for a patient to say, just give me a person, because I don't want to talk to this bot anymore. So we want to have options. And for me, I don't want to talk to anybody. I want to do it through our BayCare custom app, which we have as well. So it's about giving options to our patients, always keeping in mind the retail journey that they see in other places, and trying to match that to a very complex world that we're dealing with every day.
And Kopal, how are you seeing it from your perspective at Phoenix Children's?
So I think that they, you know, in different ways, again, I'll take a little bit from the clinical side of it. I think that they don't always see the technology directly, but they can feel it by not, you know, if the clinicians quickly have their information, they can stop asking, you know, repetitive questions, spend more time making eye contact instead of looking at the computer, and then families experience better care. But on the patient side of it, it's also, you know, can we make improvements in communication with billing with the providers, because they sometimes have a hard time accessing the providers. So can we improve that experience so that it can match what can happen on the outside of healthcare? You know, healthcare it's deeply personal, and so you need to make that experience, that journey for them personal as well. And being able to contact their providers is, I think, really important, or being able to contact the billing folks, and being able to schedule their next appointment. We have, as I was saying before, we have a lot of complex patients. Making that easier for them is really where I think it is important. And I think, you know, technology should make it feel more, you know, personal and not less. And it should also help, you know, technology can fade into the background, but so the focus remains on the family, but it's sitting in the background, helping them and their journey. So that's what I think is important.
Great. And Crystal, was there anything you want to add on to your?
Yeah, I think we've hit it. It's multimodal. It's, you know, they're trying to interact with the doctor, the provider. At the end of the day, they're just trying to get something done. A lot of times it's, you know, they're not at their best anyway when they're trying to find a provider or whatever. So it's really got to be easy, and it's got to be the way that I want to. You know, if I have 5 minutes, I might be able to have time to make a phone call to set up that appointment, but it might be 10 o'clock at night and I have a crying baby on my shoulder. And so then I just want to be able to click some buttons and do that. It might be Fred, who lives in rural South Carolina, who is not going to use that damn phone no matter what. He wants to go and talk to Sally at the front desk, and he will drive there and do that. And we still have to allow that to happen as well. Or if he does call in and gets the bot, he's going to say, let me talk to a human. And being able to handle that, as well as our super tech, you know, college kids and all those other things. We want to be able to do it in various languages so that we can meet people where they are when they are. And I think that's the promise of technology, but it's also something we have to continue to watch and make sure is accessible, because the more tech we put in, there's still always going to be a Fred. And we want to make sure that we're still serving Fred as well as everyone else.
Great. I know we just have a few minutes left here, and I want to make sure we fit in at least one audience question while we can. Thank you to the three of you again for the great conversation. And we'd also love to hear from your feedback from the audience on today's webinar. If you'd like to take a moment to complete the brief survey located at the top of your screens, we greatly appreciate your input. So going off to our audience Q&A right now, someone had asked, are you currently using AI and wearables for your nurses, clinicians, and physicians to support their wellness and better understand how you can help them optimize their health? Is that something that you guys are utilizing at BayCare, Lynnette?
You know, we've looked at like a respiratory tracker to track their breathing, but you know, we've not rolled anything out. We don't really, as far as I know, we don't really have a lot of requests for this either. I think they look for their wellness support in other areas. What we're trying to do is reduce the administrative burden that we hope improves their wellness, and really doing it from a sort of a separate layer. So no, not to my knowledge, we're not using AI and wearables to support our wellness journeys, but we do have other wellness activities that we work on with them.
At Kopal, is this something that you've seen clinicians utilizing at Phoenix Children's?
Just along what Lynnette was saying, we haven't had many requests for that. And so I think we haven't been moving into that space, but exactly what she said, if we can improve their wellness in other ways, and that's how we sort of see the benefits. But we haven't had requests for wearables and using AI to help with that.
I think there's also some concern about, you know, Big Brother watching over you if you have that, and then it goes into some system for work, as opposed to, you know, my Apple Watch kept keeping track of my higher heart rate or my feet or whatever. And so there's some of that there's still some caution on the side of employees as well.
Right. And then just lastly, I guess is a good way to end this on, but what is one piece of advice that you would give to fellow digital hospital leaders for scaling technology at their organizations right now? Crystal, is there one thing in particular that you feel like you could kind of give to some?
Yeah, I'd say like we've all said, start with a problem, start small, get it right with the front line, and then extend it accordingly.
Great. And Lynnette? I
would say iterate. So start with a minimum viable product of whatever you're trying to do, roll out, get it right, and then you know, have a repeatable process there.
Great. Kopal, any last words?
Yeah, and I would say real quick, two things is really make sure you invest in that bridge between the end user and IT. That I think is really important. And then communication, communicating, not telling them that something's happening, but telling them why and including them through that journey, I think is really important.
Yeah. Great. Informatics is surely our secret weapon.
Mm-hmm. Yes, exactly.
Wonderful. That is all the time we have for today. Before we conclude, we encourage you to share your feedback by completing a brief survey, which will appear at the close of this session. Your feedback is greatly appreciated and will help us improve future events and provide more valuable content. As a reminder, this webinar recording will be emailed to you once it becomes available. Thank you again to our panelists and each of you for attending this session. We hope to see you at future Health Leaders events.